Good morning and good evening, everybody, depending on which part of the world you are. And Dr. Truptesh and I are happy to welcome you to today's session of our very popular East Meets West webinar. The topic for today's webinar is ERCP in altered anatomy. This webinar, as you all know, is brought to you by the Foundation for Research and Education in Endoscopy, which is a non-profit organization which promotes research and education in endoscopy, and via a generous academic grant from Boston Scientific Corporation. So today, in the topic of ERCP in altered anatomy, we have broken up this topic into 4 parts. So we will have the first talk on choosing the route of ERCP in altered anatomy and enteroscopy guided assisted ERCP. And then we will have EUS guided ERCP with EDGE and PTC. And then we will have 2 case presentations on enteroscopy assisted ERCP and EUS guided EDGE. The faculty for today's webinar is we have, as usual, 4 stalwarts, 2 from the East and 2 from the West. From the East, we have Dr. Sundeep Lakhtakia from the Asian Institute of Gastroenterology at Hyderabad, India, and Dr. Majidah Bukhari from Dubai, UAE. And from the West, we have Dr. Ivo Noskoski from Rome, Italy, and Dr. Shyam Thakkar from West Virginia University, USA. A few housekeeping announcements. Whenever, if you have any questions, please post your questions in the Q&A box. And if there are any discussions or any difficulties regarding logistic or technical difficulties, put them in the chat box. And we will definitely try and cover as many questions as possible, as far as possible, all the questions. And we take this opportunity once again to thank all of y'all for joining this webinar on a Saturday morning or evening, depending on which part of the world you are. And thank you so much. And now I would like to hand over the podium to Dr. Truptesh to give any further inputs and then call upon the first speaker to start the sessions.
Thank you, Amol, and thank you for all the faculties for joining in today. I wouldn't take much of the time. I would jump straight to the podium and invite Dr. Sundeep Lakhtakia. His topic for discussion today is choosing the route for ERCP in altered anatomy and enteroscopy assisted ERCP. Welcome, Sundeep. All yours.
Can you hear me now?
Yes.
Okay. You see my slides too, Truptesh?
Yeah. Yeah.
Okay. At the outset, I would like to thank both organizers, Truptesh and my friend Amol, for inviting me to this fantastic conference where the global experts get together. And today's novel topic is on enteroscopy guided ERCP in surgically altered anatomy. I will stick myself only to choosing the route for ERCP in altered anatomy. I'll let Majidah speak on the enteroscopy guided mainly, but some of the parts I'll cover here as well. It's whenever we have a surgically altered anatomy, then options sometimes get limited. If regular ERCP is not possible, then we opt for either enteroscopy or EUS guided. However, having said that, even sometimes if we have a short afferent loop or if the scope can go across even after surgical anatomy, you can use a regular duodenoscope or even a forward-wing endoscope, among which you include a colonoscope, pediatric colonoscope, or a therapeutic upper GI scope, or if sometimes even a regular upper GI scope can do the job. It's important to understand the variations in surgically altered anatomy. There are several types available which can pose different challenge when we proceed with the case. We have to understand our access route, the standard devices, and the assisted devices scopes that we are available. The several cannulation techniques which get altered And alternate methods of backup plan should also be ready in case we fail with the first mode of treatment. The first and foremost challenge is finding the correct afferent loop. If you have a anastomosis, a GJ or a long afferent loop, which way to go forward, because sometimes you see more than one loops on the endoscopy view, turn right, turn left. There's always a challenge. Once you cross that barrier, the next barrier comes in selective cannulating. Either the papilla, if the papilla is intact, or if it's as a surgically altered anastomosis, biliary or a pancreatic anastomosis, then cannulating that duct of choice. And beyond that, again, the main hurdle again remains is tackling the major problem for which you started off. For example, if it's a stone, small stone, generally no problem if you reach there, but large stone, then how do we break it? We don't have long cholangioscopes, and then we need accessories which have to go all the way through the enteroscopes if you're using and including stents and metal stents, which have some of them have short wire systems. So one must be aware of the accessories available in the room. It should not happen that you reach the target and then you're not able to deploy what you plan to do. I would like the audience to just focus on this slide, how they differ when we have to do a biliary intervention or biliary pancreatic intervention using one of these devices, enteroscope or ERCP. The accessories are limited with enteroscope. They're now reasonable with EUS currently available. An exchange of accessory during the procedure is sometimes very slow and can be cumbersome and difficult with enteroscope. It's reasonably fast with EUS now. Enteroscope does not have an elevator, but EUS has, so you can hold your accessories and do. The procedure time is much higher with enteroscope, even on expert's hand. It's also long with EUS, but sometimes it's with expertise, it's now becoming more and more efficient. The difficulty of the procedure also depends on the expertise available, and these can vary from center to center. Cost can vary also depending on the procedure and the center. Adverse events are known with both of them. And enteroscopy is generally used for a benign indication than malignant indication. If it's a malignant, then more often EUS can do the job. And repeat procedures can be done by both of them, and both are equally cumbersome, although EUS much lesser than the enteroscope. It may differ from, we can debate it on later on. Another important area to understand is the surgically altered anatomy. So you have to review the operative notes or speak to the surgeon who's done the job. It may be a very good idea to have a surgical map at the time of the procedure, what surgery was done. I wish most surgeons share this kind of a cartoon of what was done. I wish we had a standard images which are available in a line diagram or a figure, cartoon figures, which will help us make it understand easy. Nevertheless, we also have to understand what are the imaging showing us, map out the ducts and the relationship of the ducts to the bowel. There are some situations where the afferent loop is short, and these are much easier to navigate. Is, for example, Billroth 2 anastomosis or a Whipple's procedure with a short afferent loop. Even total gastrectomy with a Roux-en-Y also has a shorter afferent loop. The ones which have a long afferent loops are Roux-en-Y with an HJ after bile duct resection or after Roux-en-Y gastric bypass surgeries. So these are the ones which are very, very difficult even by an expert enteroscopist. And duodenal switch has the longest afferent loop, and it's worth not wasting the time further and use for alternate methods rather than going to enteroscopy. So some of the short limb variants, this is a Billroth anastomosis where you directly can enter the duodenum, so no problem. Billroth 2, the afferent loop is generally short and can be entered. One must also know about the retrocolic or the anticolic GJ. The retrocolic GJ is much easier to reach. The afferent loop is pliable and can be entered easily. It's shorter also compared to the anticolic, which is much longer and can pose more difficulty and risk of perforations. Whipple's procedure, post-Whipple's requiring of ERCP is also there. And one must be aware that when you're doing a Whipple's procedure ERCP and the GJ, the right loop on the endoscopy view is the right loop, which is the biliopancreatic limb where you have to enter. But if it's in a pylorus preserving GJ, the first one is a classic GJ where the pylorus also goes away. But in the pylorus preserving, it's the other way around. The afferent limb is on the left of your scope. So one should be aware of that. Then these are long limb variants. This is a Roux-en-Y surgical gastric bypass, and this is a very long afferent limb. And this is what I meant was extremely long afferent limb where there's no point going all the way up to ileum and then ascending up to the biliopancreatic limb. So let's come to the EOS guided enteroscopy, ERCP, enteroscopy guided ERCP in altered anatomy. So here we have both double balloon and single balloon, standard and short. More often now, the short length scopes are being preferred. The other scopes are either out of vogue or hardly used. Then the radius of curvature of some of these enteroscope is important. And that's where the pediatric colonoscope has a very acute bend available at the tip. And this sometimes is useful, especially if you're having a short afferent loop. I will show you why. If you see this picture, this is the papilla. If you reach here, you will not be able to cannulate this papilla. But you using a pediatric colonoscope, which can bend almost at 180 degrees, then you get the papilla half face and cannulation becomes much easier. So scopes which have a good radius of curvature at the tip give flexibility of cannulating the duct of choice. Let's come to some examples. This is a patient who is a 70-year-old male who had a biliary stent placed after CBD clearance and was inside for a long time. Then he had a distal gastrectomy and duodenectomy and this forgotten stent for a large neuroendocrine tumor and cholecystectomy. He now comes with cholangitis and choledocholithiasis. So this stent is now causing problem, the forgotten stent, which is quite common in India. So let me show you this video, which was given to me by Anuruddh, my colleague at AIG, who is expert at this. So this is the single balloon enteroscope, the short one, which is being passed forward. And you see the stent there. So Anuruddh grabs this stent with a snare and pulls back. And then, let me just move this little forward. You see and that's the opening. He then cannulates with a balloon and goes inside the biliary tree, gets a good cholangiogram, clears up the secondary stones, and then solves the problem. So these are some of the problems which can occur. A second case with post-GJ with multiple comorbidities, gallstones and CBD stones, cholangitis with relatively, and he is now come for a pre-operative. He is now due for gallbladder removal after settling his cholangitis. So he comes here now with for an ERCP. So he's changing from a forward viewing, a tapered cannula to a ball tip cannula, which is sometimes makes his job easier. I'm sure Majidah would touch upon that. A cap at the tip helps in cannulating the biliary tree. Probing the papilla is better. And once you're inside, then you can dilate the papillary orifice because the sphincterotomes may not be very easy. Although here it is using a sphincterotome because of lack of elevator. So it has to be very carefully done. And then dilate it's just like a EPLBD where you make a small sphincterotomy, then dilate with a balloon, and then remove the stones which are there inside. That's the stone. Just come out. And he places a stent for the ease of procedure subsequently. This was a video shared by Dr. Greb Haber in a patient with total gastrectomy and Roux-en-Y anastomosis. So once you enter the afferent loop, you go all the way up to the stump and then withdraw back after seeing the minor papilla. And here you see the major papilla and then cannulating it. The cap helps in assisting in cannulation, which is a standard process. Don't do enteroscopy without a cap. He's nicely passing the guide wire deep inside. And once injecting, you'll see the stricture very nicely here. You cross the stricture with a guide wire. Then you can do the regular procedures. Take a brush, which is over the wire guided brush, to confirm the diagnosis in this patient. And while waiting for the report, you can place a plastic stent and come back. And once you have a stent inside, that becomes a landmark for future interventions as well. This is another video where device-assisted enteroscopy is helping. This is will tell you how the moves. You have to fill some water inside the jejunum, just like we do underwater ERCP, underwater colonoscopy. Sometimes even enteroscopy is useful to find the roadmap, effacing the folds and finding the papilla. And once you reach the papilla, then you can cannulate it, again using a forward viewing cannula, a forward taper tip cannula. So this is the route of the pancreatic duct, and the left, just like we do for the ERCP, is the route for the biliary tree. You pass the guide in the biliary tree and dilate the sphincter, the papilla with a balloon, and then drag out the stones. So cutting is not so easy at the papilla, unlike ERCP. It's stretching the papilla is much more preferred, especially the stones are small. There's another video which is shared by Greg, who has a stricture now at a choledochojejunostomy site, a very tight stricture, which he manages to cannulate with a wire, but the devices are not following inside. So then he uses a needle knife. None of the devices were going in, so he uses a needle knife and cuts besides the wire. So you see here the needle knife comes, and he's cutting in a radial fashion in a different direction. Very skillfully done. So tight fibrotic stricture is opened up, and then you can then dilate the stricture with a balloon and manage it. So the access in the short limb variants can be used apart from enteroscope, can be used with a regular duodenoscope, a pediatric colonoscope, and a gastroscope, especially a therapeutic variant. This was Majidah's paper, and I'm sure she will touch upon it, where they compared EUS versus enteroscopy, and they found the results were equal. Sometimes complications do happen with an enteroscopy. Let me show you one. This was a patient again with GJ and multiple comorbidities. So the plan was to remove the stones, which Anirudh nicely did that. And I'll keep forwarding the video. Same process, do the small sphincterotomy, dilate with the balloon, remove all the stones, the larger stones coming out one by one. And as he's coming back, he starts seeing the air around. And then he sees there's a big opening around, which he tries to close with a clip, but it's not very successful. Closing these defects of the enteroscope is not very easy. So he changed over the short balloon enteroscope using a regular forward-wing endoscope, and then using a king closure technique using the loop and clips. This opening was repaired, and then patient was kept in already, and these are multiple clips, and the contrast is flowing easily. There's no leak out. So patient was asymptomatic after the procedure, but this was luckily detected at the time of procedures, and it was closed appropriately. So one must be aware that some of these loops can be retroperitoneal, and going around these corners can pose a challenge. So whenever we move in the posterior part of the retroperitoneal part, that junction between the intraperitoneal and the retroperitoneal junction can cause perforation, especially if they're very angulated. So try not to force your way in once you're trying to do an enteroscopy, or even using a regular upper GI therapeutic scope, forwarding scopes. Changing gears now, EUS-guided ERCP also in surgical anatomy is quite useful. I prefer this personally. And this is hepatogastrostomy. If you have a stomach stent left and somebody has a malignant biliary obstruction, then this may be a reasonable option rather than going all the way with enteroscopy and doing it. Let me show an example. A patient of carcinoma stomach with distal malignant biliary obstruction comes back with obstructive jaundice, and we did an ERCP, EUS guided intervention. You see a very tight stricture in the lower end. The PET scan was positive, showing nodes in the lower end of around the CBD. And we were fortunate that the guide wire then went across the papilla. And this gives us two or more opportunities. One is either we place an antegrade stent or we do hepatogastrostomy. Both options are available in this patient. But since the papilla is normal, we went ahead and did an antegrade stenting using uncovered stent at the lower end of the CBD. Let me show you a case with benign biliary stricture who had a surgically altered anatomy. This was a patient of chronic pancreatitis. A chronic pancreatitis who had undergone a surgery a long time back with head coring. And we were not aware that the patient had a biliary jejunal anastomosis. We were presuming that it's just a LPJ. And when we did ERCP, we failed repeatedly. So we decided to do an endoscopic ultrasound guided procedure. And this was the EUS. It showed the dilated duct. So standard procedure, pass the guide wire across. And once we entered when we injected the contrast, then we realized that it's going into jejunum and not the duodenum. Still, it looked like a duodenum to us. And nevertheless, we placed a fully covered stent because this was a benign disease. Later, we realized that it was a jejunal loop. We placed a short 4 centimeter fully covered stent in the distal limb of the CBD and which was going into the jejunal limb. We reconfirmed that we were not missing the papillary stent coming out of the papilla, but here we see that it's nothing there. After 6 months of indwell time, the patient was then called back when she was okay. And then the stent was removed through the enteroscopy route, because removing the stent by EUS now becomes difficult. And that's why we have to collaborate with each other. The stent is being removed. The problem over here is that once you remove the stent, you have to draw back the scope all the way back and recannulate it. So what Anirudh did was to go beside the stent while pulling it back using a cannula, so that we can get a cholangiogram to at least ascertain that the stricture looks to be reasonably opened up. And here you see that the stent is just out and the stricture looks to be opened up. And then he followed up with removing the stent completely. And the patient has been on follow-up for more than a year now with no recurrence of stricture. Another interesting case which I would like to share, some of you may have seen it. This was a patient of Whipple's procedure many years back, came back with a biliary obstruction. We often do a PTBD in such patients. In 2014, she had a PTBD with serial exchanges over 1 year at 3-month times, and the stricture opened up. She remained well for next 7 years. So 5 years between the surgery and the first stricture, and between 7 years between the stricture management percutaneously, and then she comes back and had cholangitis. And this time she did not want any more percutaneous interventions. We did an MRCP which found a large stone here in the biliary anastomosis with a jejunum. So we did an EUS guided intervention now. And as you can see, we placed an HGS stent, a fully covered stent this time, and then placed a plastic stent across it. This stent, we allowed it to expand over a period of 3 weeks, and then attempted an endoscopic intervention through this route. So removed the plastic first and then went through the stent into the biliary system, hoping that we'll reach across the stricture, dilated, and pull back the stent, and after tackling the stones. So we passed the stricture using now, we tried the first 9 mm scope, which did not go through, although stent was 10 mm. Then we tried a pediatric endoscope, hoping that we'll go across, but even that didn't go because of the angulation, almost 90-degree turn. We then tried a spyglass over the wire. So we kept reducing our diameter of the scope used so that we reach the stone. This did take us to the stone, and we did do a lithotripsy, spyglass lithotripsy with laser. And we're presuming that this would solve the problem. But as we move forward in the video, you'll see that the stone is getting broken, but it's only the edge of the stone because it's a 90-degree turn. And even a cholangioscope are not so flexible enough to take a downturn from the common hepatic duct downwards. So we only managed to break the stone partially. I'll show you the cholangiogram. This was a cholangiogram, still a large chunk of stone is still there. So then we withdrew it, dilated the anastomosis, placed the stent back, and then placed a nasopiliary tube to break the stone using extracorporeal shock wave lithotripsy. Once that cleared up the stone, then we did a dilation again of the anastomosis, biliary regional anastomosis, and cleared up the duct. We left the stent in situ for a short while, removing the metal, just leaving the plastic. And later we removed everything. And you will see, this is how the anastomosis looks like. The patient is on my follow-up for more than 2 years now, and she's doing quite well. So this is how the final procedure looks like. This was at the time 3 months later, and then we pulled it out completely. So she is stent-free, symptom-free, hoping that the symptoms do not come back. Very rare we use EUS, and last case, please. This is the last case. We use EUS with enteroscopy as a combination. This was a patient with post-Whipple's biliary and pancreatiginal strictures. He had a biliary stent, and we used balloon enteroscopy for again by Greg Haber. This is a biliary stent being crossed and entering the pancreatic limb, pancreatic anastomosis. It's a very tight stricture here. So could not be cannulated. So EUS was done. PD was cannulated, contrast injected, guide wire passed across the stricture, and then using a roundabout procedure with an enteroscope, the wire was beside the wire cannulation was done, and the stricture could be managed. So not only by ERCP, even with enteroscopy, we can do a hybrid type procedures. So in the end, I would like to conclude that during surgical altered anatomy, patients who come with biliary or pancreatic pathologies, understanding the surgical anatomy is crucial, which will help us decide which scope to start off with. Those who have short afferent loop can have a forward wing endoscope, either of the enteroscopy variety or even the non-enteroscopes also. Long afferent loops, I think it's better to do with EUS interventions. One has to be innovative and collaborate with the ERCP, enteroscopy. The team around should help you bail out of the crisis. Thank you very much for the kind attention.
Thank you, Sandeep. That was really very impressive. And the entire approach to how to handle these difficult situations. And our next speaker will be Dr. Ivo Noskoski, and he will be taking us through the EOS guided ERCP route in a little bit more detail, and he'll also be talking about the edge and the edge procedure, and also give us an overview about the role of PTC in these patients. Over to you, Ivo.
Thank you, Amol, and thank you to both for the kind invitation to be part of this amazing webinar. So, sorry, okay. These are my conflicts of interest statements. And this is just some few slides to tell you how important is ultrasound. Today, for who is doing ultrasound, not doing ERCP is like walking with one leg. So it is a very important and precious device. And for several years, we have been using it also as an access in ERCP as a failed drainage, because alternative is percutaneous drainage. It has been also suggested by SJ to use this. And you can see by literature how effective is the EOS directed biliary access. You can see here a video. Sometimes it could be impossible to see the papilla or impossible to cannulate the papilla. This is an old case. In this situation, you just should evaluate where the bile duct is. You can do this from the liver. If the bile ducts are dilated, you can do this from the bile, from where you see the bile duct. Then it is punctured with 19 gauge needle. You inject some contrast, you see the bile duct. And it is very important to see in a stable position and not to abandon it. And you need someone that is very skilled in wire maneuvering, because it can be difficult to pass. Or in this, if it is a benign disease, of course, you can do a choledochoduodenostomy, or mainly in, if it is a malignant disease, you can do choledochoduodenostomy, or in a benign disease, you can do a rendezvous, like in this case, where the tissue was resected following cannulation of the bile duct if the patient is old. So there are many different situations that should be evaluated here. Other situations are these. You can have anatomy that are different from a normal anatomy, like Byron 2, Whipple resection, pylorus preserving pancreatic duodenostomy, Roux-en-Y, esophagojejunostomy, Roux-en-Y, hepaticojejunostomy, or Roux-en-Y gastric bypass. So it is very important to know anatomy, to identify the correct loop, to navigate the loop, to identify, cannulate the papilla and bile duct or pancreatic duct, make sphincterotomy, deliver therapy, and consider the overall conditions of the patients in this situation. So this is how Biowork 2 reconstruction looks like. Thanks God, ultimately we don't see a lot of these procedures unless for malignant disease. In the past, before the advent of PPIs, these procedures were done to cure hyperacidity and to cure ulcers. So we see less and less these procedures. Mainly ERCP can be also easy in these cases. You need to be trained on how to get the papilla, but sometimes it can be very difficult to reach the papilla. So like Sundeep showed, you should navigate the loops and you should be very careful. There are some particular situations where Roux-en-Y, esophagojejunostomy, hepatico, and gastric bypass are particular. So this has been just shown. And on how to reach the papilla in Roux-en-Y is probably one of the most utilized approaches in obese patients. So you can use the standard route using 15, 16 or bigger trocar, and there is a vast literature also on this, or you can use this approach, which is done by us totally. We do not need surgeons for these unless we don't have complications during the procedures. So this is the EDGE procedure, and the first description was done by Michel Calais, our friend, back in 2014. And this is the very first video that enthusiasmed a lot of people. So the excluded stomach looks like a nutshell. You puncture it, you can do direct placement of the lumps or use a needle. It depends on the situation. It's a safe procedure with a technical success rate that is close to 100%, clinical success rate that is 91%. So if you want to see the details, you can read this very nice publication. And it is cost effective compared to laparoscopic approach and compared to the double balloon enteroscopy. I'm showing you here a video of a difficult procedure that I had during a live case. So once you have identified the stomach, sometimes it is not easy to identify it. Sometimes you see just the intestine. So here what it happened, I identified the stomach, the nutshell, but it was not dilating. It was very difficult to inject. I injected almost 1 liter of saline blue and some contrast, and it was just flowing away. And when I wanted just to go directly with the axios, it was closing back again. And I did this in France, where Buscopan is not available. They use different type of antispastic drugs that didn't work here. So you can see the stomach is simply the injection is vanishing, and during the punctures there was also some contrast outside, you can see here, but nothing happens. So I repeated this several times, and then finally I could see nicely the dilating stomach, and then I inserted the axios stent, which is a lumen opposing metal stent. So pay attention, you should use a big stent, 16 Spaxus or 15 to 20 millimeters in diameter axios stent. And I prefer leaving a wire always in this patients because there could be also detachment. Some people prefer just not to use the wire to place the stent directly, and in my opinion, the most of the complications occur in this situation. So you have seen the jumping directly to after 2 days. We waited for 2 days for the stent to accommodate. It was dilated, and I switched it with the overstitch. You can also fix it with the clips if you do not have the overstitch device. We had it, so it is a simple procedure to fix the stent in the place. Usually we use 2 stitches, one cranially, one caudally, and it is enough. You suture the stent and then full thickness the gastric wall, and this is quite easy. You should be confident with this procedure in order to make it work properly, and be aware of not touching the stent, otherwise it can be dislodged in these patients. And probably the contrast was the injection was running out away because of altered anatomy or whatever. It can happen sometimes. And this procedure was completed then with ERCP. I don't know why it stopped. However, it's straightforward and easy. This is the first part. Okay. Another access of the and then you can perform ERCP whatever the patient needs, either for benign or malignant procedures. Another access is this, so you can access the left lobe of the liver with a needle in case you want to do gastrohepaticostomy, and it depends also of the anatomy of the patient. It can be used in Roux-en-Y esophagojejunostomy, which is the most difficult situation, Byrod 2 or other surgically altered anatomies, or in a stricture that involves the duodenum from the bulb, where choledochoduodenostomy is not possible, or there is a hilar stricture in the patient. So we prefer to use 0025 wire or maximum 35 with a 19 gauge access needle. There is also vast literature on this. A lot of combinations can be done in the drainage. For who is interested, can go through the type of treatments here. Some technical notes that are very important. The maximum distance is 2.5, maximum 3 centimeters from the probe, from the probe to the bile ducts. So this is the maximum. For safety reasons, you should be not above 3 centimeters. So this is why it is very important to measure. Nothing happens if you puncture some small vessels in the liver parenchyma, but also always be aware of these kind of situations. You see the needle, you should push very, very slowly the needle to the biliary ducts. Don't be fast like we do it for with the stomach sometimes. So very gently pushing the needle towards the bile duct. It can be round like this or oblongated. In every case, you should be very precise. So if you go on the other side with the needle, just retrieve it slowly, inject some contrast, be sure that you're in the bile ducts, and then you can advance the needle. You can see here under endoscopic ultrasound the wire in the ducts and the contrast inside the ducts, and the injection is done also under direct vision. It depends also how much the ducts are dilated. Also here you should have a very good assistant that maneuvers the wire inside the bile ducts, and you should avoid very acute angulations, because this can prevent from a correct placement of the stent, and can make it malfunctioning after the procedures. So here it is suggested always to use, if you don't have the jobber stent, to use an 8 centimeter long stent partially covered in order to fix it nicely inside the liver and then to prevent migration. You can also leave a double pigtail stent. Sometimes it depends from the anatomical situation that you have in that liver and what is the purpose of the treatment you're doing. In this case, we left an 8 centimeter stent. It is left inside the endoscope, so you should check and also endoscopically during the placement, but this is ERCP procedure. So the ultrasound here finishes immediately after the puncture of the bile ducts and after safe placement of the wire inside the bile ducts. And this is the final aspect of the stent under ultrasound and under fluoroscopy. As it concerns pancreatic drainage, it depends what you need to do. And of course, here ERCP is done, it's ERP procedures done on the Wirsung. In Italy, we have available the secretin for MRI in order to study the situation. Sometimes there is altered anatomy, like Whipper's procedure and so on, that you need to treat these people on the Wirsung duct. And the procedure is the same under endoscopic ultrasound. Puncture of the duct is done, wire is placed, and then you shall dilate or use a cystostom in some situation and then place a stent according to the nature of the disease. This is another live case. You can see here the identification of the Wirsung duct. Also, this is a live procedure, and this is very easy. We usually call people in training to do these kind of procedures. You should see how dilated the bile duct, the pancreatic duct here is. This is in an altered anatomy of a patient. So you can see if it was 14 millimeters, so it is a big dilation of the duct. And the only problem here is that there is a lot of fibrosis of the pancreatic parenchyma, even though it is a very short route to go directly to the Wirsung duct. And sometimes you can stuck with the needle inside the parenchyma because it is totally fibrotic in some patients. So at this stage, it is punctured with a 19 gauge needle. So this is a live procedure, and there was a lot of talking and questions. So this is the needle going in the duct. It is always nice to inject contrast to be sure that you are inside the duct. Here I didn't did it. I was very confident that I was in the duct, so I maneuvered the wire by myself. I saw it in the duodenum directly, so it was quite easy procedure. Then at this stage, contrast is injected also, and balloon dilation is done, and stent is placed. You can place one stent or place a second stent. You see it was sometimes can be bleeding. We had only this long stent in that moment, so I usually place shorter stents in these patients. So choledochoduodenostomy is another approach that we do with endoscopic ultrasound, especially in pancreatic cancer or, of course, malignant strictures of the bile duct. This is a very easy, very straightforward case, very didactic, and you see here the freehand placement of the axial stent. You see it nicely comes in. Wire is not needed in this case. Sometimes also a fluoroscopy is not needed if you're pretty confident. We use small stents 6 or 8 millimeter. In this case, it is very important not to pull too much on the stand because it is very, very fragile. You can pump it in the duodenum, but in this case, you can, on the axial stand, you can reload it again. There are some tutorials on how to reload an axial stand on just pushing the thumb on the stand and reload it again, and then place it again in the correct place. This is another video. You see, before we show circular bile duct, here it is oblong, and also this is a very easy case where the stent is placed directly under only ultrasound vision inside the bile duct is open and easily deployed. If we go in PTC, this is one of our last cases here. It is a 26-year-old boy that had a laparoscopic cholecystectomy with vascular injury, and it was bismuth and lazortus type 4, a disaster at the hilum. We could see this. There was biliary drainage. Then this is what was left from the liver. Percutaneously, it was punctured, and it was we made a rendezvous inside, and it was impossible due to angulation to go inside the left ducts here. So we used a snare from operative radiology. It is a very small snare. You can see it here that catched our wire, brought it inside the liver. Then we placed one stent here, one stent there, and then every 3 months we exchanged the stent. And this boy that was in the list for liver transplantation, bilirubin was 40 times the normal range, was saved and is doing very, very well. And by the end, this is a case of a total obstruction of the bile ducts in liver transplantation. This patient had 2 liver transplantations, and it was impossible to reoperate. So we designed neodymium magnets that were made in Milan, in Italy, for us. These are 16,000 Gauss magnets that attract also up to 3 centimeters, so 1.5, almost 1.5 Tesla each. And you can see here the placement of the magnets. You see how important it is to have radiological coordination and endoscopical coordination. These are placed over the wire, and this is the kissing method. We also tried laryngoscopy in this patient. Obviously, it didn't work. And this is the moment of the release of the magnets, and you can see how distant they are. And almost after 14 days, they attached, and we could. This is 15 days, yes. And then an ERCP was performed, but we could not retrieve out the magnets. It was very difficult to pump them out. We tried several devices, balloons, and so on. And when we buy this, we don't buy these magnets. They're given to us for free, and they come and we place epoxy acid on the magnets, and in this way they become atoxic. And you see, it is almost impossible to bring them out. So we made this custom-made, very brilliant device in a sterile mode. It was placed over a catheter. I don't know, it was a device very difficult to find. I mean, you should be very open-minded and do not harm the patient and do only what is good for the patient. And so it worked in vitro. It was attracting the magnet from afar, and we tried on other magnets outside that it worked very nicely. And this is how we retrieved the magnets out from the patient. Of course, this was a very complex case with PTC and skills demanding. And at the end, the magnet was retrieved, stent was placed, and this patient was discharged in very good conditions, and stents were exchanged every 3 months up to 1 year. So this is everything for me. If you have any further questions or whatever, you can contact me. Thank you.
Thank you, Ivo. That was a brilliant presentation. We really are attracted with the presentation, and the magnets are a great thing, and it's a new. It's almost been practiced and shown multiple times as well on the Indian forum as well. Saving time again, we are almost running 10 minutes behind, but I would like to invite Majidah Bukhari. She's going to speak on enteroscopy assisted ERCP. Majidah, all yours. You're muted, Majidah.
Can you hear me?
Yes.
So we have a 44-year-old male with gastric cancer. He underwent a total gastrectomy with Roux-en-Y esophagoduodenostomy back in 2022. He presented to our hospital with abdominal pain, weight loss, and obstructive jaundice. He underwent a CAT scan, which revealed a mass was measuring 5 by 5 with marked dilatations of the intrahepatic and bile duct, was suspicious for a stricture. And there was also multiple para-aortic lymph node and multiple peritoneal carcinomatosis. So what is the management approach for this gentleman to relieve his obstruction? So basically, we tried to do a single balloon enteroscopy assistant ERCP. You can see here, we saw the esophagoduodenostomy. We tried to traverse the limb to be able to reach to the J anastomosis. And we negotiate through the limb. Initially, we went through the left limb. We wish that we have a road sign. We will be able to identify the targeted bile duct or pancreatic duct. So initially, we went through the left to the right side of the limb. And when we actually did fluoroscopy, we saw that we are going to the efferent limb. We injected contrast, and we saw that the contrast going to the pelvic area, and we are not progressing to the afferent limb. So we withdraw the enteroscopy. Unfortunately, we did not use the cap during the enteroscopy. So we went all the way to the JJ anastomosis, and despite multiple attempts to be able to reach the papilla, we were unsuccessful. We can see in the fluoroscopy, we're trying to reach, I think because of the mass and because of the peritoneal carcinomatosis, we were unable to reach the targeted papilla for cannulation. So the patient was actually cash, and we were thinking what is the best option for him. We know that EUS will not be an option for this gentleman. Surgery is an option, but we know that he has a peritoneal carcinomatosis and he's cash. So we, at the same time, we decided to do direct colonoscopy via percutaneous intrahepatic approach using the spyglass scope. So we were lucky in our institution where we talked to the radiologist. The radiologist placed the percutaneous transhepatic axis. They dilated the axis to 12 French at the same time, and we advanced the colonoscope via the sheets. So we did not wait for 2 weeks to be able to do the colonoscopy, so we did it at the same time. There was, we entered the colonoscopy. There was a stricture down. We tried multiple times to pass the stricture and advance the guide wire. It was initially difficult. And finally, we passed the stricture. And we went to, we inject contrast, and we know that we are in the right direction. After that, we see that there is obstructions in the bile duct. We dilated the tract, and then we went again with the colonoscope, and we saw that there was a polypoidal lesion present in the distal bile duct. and we took multiple biopsies, and we were unable to place any stent through the colonoscope, as you guys know. So what we did, we placed metal stent through the percutaneous approach to relieve his obstruction. And luckily, the patient was doing well after the procedure for a few weeks. And unfortunately, he died because of the chemotherapy after gastric surgery. So you can see the advantage of direct colonoscopy, that it will allow us to take direct biopsy and also to evaluate the stricture. And because of his altered anatomy, with direct colonoscopy is giving advantage of us seeing what is inside and taking biopsy better than just do it under fluoroscopy. So this is my case for today. We can talk about Sundeep went through all the enteroscopy assistant ERCP. We know that in terms of the options of enteroscopy, we have double balloon and single balloon, and now we have the short double balloon for both double and single balloon. And the meta-analysis show that the success rate of reaching the papilla was 89 in the double balloon and 86 in the single balloon. And the cannulation success rate of the double balloon is 93 in comparison to 68 with the single balloon. A spiral enteroscopy is very good, but the problem that it was withdrawn from the market. And in a large multi-center comparative study, compare both double balloon, single balloon, and spiral enteroscope, and showed that the ERCP technical success was similar between 3 scopes. And as Sundeep, I'm not going to go through what he was mentioned, that there are lots of challenges of doing ERCP in altered anatomy. Recognizing the afferent limb is very important. Reaching the ampulla of Vater is also cannulations, because we know that the papilla is upside down, is very difficult to negotiate and go through the ampulla or the pancreatic duct. Also because the enteroscope has forward view, lack of elevator, unstable position with limited accessibility. So in the past, the standard enteroscope, we were unable to place metal stent or 10 French plastic stent. But now with the short scopes, and they have wider diameter, so 3.2 will be able to place more therapeutic and more accessories of the standard ERCP. Also the challenges of enteroscopy assistant ERCPs required longer durations, even in expert's hand, and the success depend on the available expertise and selected tertiary center. So in these patients, as I say before, so we are actually limited in terms of the options. Should we do transhepatic cholangiography with direct colonoscopy or surgical access? So a SPY scope has a lot of advantages that allow us to see the biliary stricture and provide direct biopsy for accurate diagnosis. And the SPY discovery have 4 tips, deflections. They have independent irrigation channel where you are able to maintain visualizations of the bile duct or any stone if you want to do any intervention with the lithotripsy. And the other thing that we can place the colonoscope, and we don't need to dilate the tract larger than 12 French. So it's less painful, and the new SPY scope have a greater images resolutions to allow us to visualize the bile duct in comparison to ERCP. And it's completely disposable, so there are less risk of the infection. However, this disadvantage cannot be done in acute cholangitis because they are with the SPY scope with continuous irrigation. There is risk of septicemia, abscess, and infection. So again, it's required experience. A hand may require tract maturations. I know most of center, they are waiting 2 weeks to do it. But in our center, most of the time we do it on the same spot. We need to place the PTBD during the treatment options. And the other disadvantage is the cost, especially in people working here in Dubai. We have the DRG, so sometimes also the spice scope and everything is not covered by the insurance. So it's a huge loss to the hospital. So comparing to ERCP, PTC with direct colonoscopy is very good options. The PTC itself, it's an invasive and time consuming, but it's better than laparoscopic or surgery because the surgery is associated with more risk of complication. However, there are adverse events with percutaneous transhepatic cholangioscopy, including liver laceration, intra-abdominal abscess, cholangitis, bile duct perforation, disruptions of the PDBD, or hemophilia. So that's why it's recommended to wait for 2 weeks if can. If not, then we need to use the sheets for to be able to do our intervention. There was a retrospective cohort study of 13 patients with altered anatomy. 4 of them were Roux-en-Y hepatocoagulopathy, 7 were seven with hepatocoagulopathy and 4 with colodocoagulopathy and 2 with esophagocoagulopathy. The success rate was 100% technically. The total procedure time was 42 minutes and there was no adverse event. So in conclusion, patient with altered Roux-en-Y anatomy, traditional ERCP is technically challenging and clinically ineffective. Over the decade, there are multiple techniques are available to be able to reach to the ampulla to perform the ERCP, and we have to know that one size does not fit all. Spyglass offer direct cholangioscopy. Spyglass direct cholangioscopy assistant PTC is safe and feasible and effective procedure in diagnosis and treatment of biliary disease in patients with surgical altered anatomy, particularly in patients with Roux-en-Y reconstructions or if they have long limb. Thank you so much for your attention.
Thank you, Majidah, for that interesting case and an overview about the percutaneous cholangioscopy. And now we have Dr. Shyam Thakkar from the West Virginia University in the US. He will talk to us about EDI and some other innovative approaches to ERCP in altered anatomy. So over to you, Shyam.
Thank you, Amol and Truptesh, for inviting me to be a part of this fantastic webinar. It's my pleasure to speak to you about ERCP and altered anatomy. And yes, I'll take a little bit of different approach in talking about EDI procedure, as you've learned a lot now of the different approaches when it comes to edge as well as long limb ERCP. So if I can just move forward here. There we go. Okay. So brief history. This is a 41-year-old female who presented with intermittent abdominal pain and and fevers for more than 15 years. She has a history of cholecystectomy in 2005 for symptomatic gallstones. Her cholecystectomy was complicated by a questionable bowel injury requiring a Roux-en-Y hepatojejunostomy. And so her labs on presentation, her total biliary was not significantly elevated, just mildly elevated at 1.6. However, she continued to have more significant LFT abnormalities in terms of transaminitis and cholestasis. And so a CT abdomen and pelvis with contrast was performed. And here you can see on her CT scan. Oh, whoops. There we go. Try that again. Here you can see on her CT scan the dilated biliary tree as well as some pneumobilia. And this ends at a level of clips. An MRI was subsequently performed to further assess her biliary anatomy. And on MRCP, we see similar findings here of dilated biliary tree. And the ultimate image here demonstrates intrahepatic biliary dilation to the point of what is suspected to be the anastomosis. So I'll pause here and we can talk a little bit about the treatment options and perhaps open it up for the panelists as well to discuss these different types of treatment options. You've heard already about the PTC approach, enteroscopy assisted ERCP approach, and then we would consider the EDI approach unless any of the panelists want to make any additional comments with respect to this case.
I think all the three approaches are feasible, but again, EDI is the most one of the least minimally invasive compared to the other three approaches that I think.
I would agree, meaning I would definitely resist an enteroscopy assisted approach, because I personally feel it's very, kind of time consuming and painful. I think anything US guided is definitely much more, works better probably. That's what I feel.
Yeah, so in this case we suspected that the patient would potentially require multiple interventions. So we wanted to explore the EDI option in a little more detail. I see Majidah is there as well. Or could you just unmute Majidah?
Yes, I think endoscopic direct transhepatic, the AD is the best option for this patient.
So let's talk about what EDI is. So essentially, it's an enterostomy or gastrojejunostomy, ERCP, where essentially what we're doing is creating access from the stomach or the duodenum into the excluded roux limb at the time for the purpose of ERCP. And so here you can see the still image of the coronal view of the CT scan that was performed. And first, we can identify right here the choledochojejunostomy. We can also identify here the blind loop of the afferent limb jejunostomy. And then finally here, we can identify the loop of duodenum or stomach in close apposition to that loop of jejunum. So we felt that this patient would be an excellent candidate for a EUS-guided enterostomy for the purpose of ERCP. And so here you can see under EUS, we actually can see the biliary tree essentially tapering nicely at a point of stricture. We don't see a mass lesion, so we were very suspicious of an anastomotic stricture. And there you can see the roux limb as well. So under EUS, we simply stick our needle, and we use the direct approach for creating this gastrojejunostomy or enterostomy. And simply by injecting our needle, we can then distend that small bowel with a combination of sterile water, blue dye, or with dye in it as well, or methylene blue. And here you can see once it's adequately distended, how well those loops can be identified. Interestingly, what we would have liked to have seen in this case, obviously, is a biliary tree so that we know we're in the exact appropriate loop. But unfortunately, the degree of stenosis of that anastomotic stricture was too great. And so here we could at least identify that it was the blind limb, and more than likely this was the area of the anastomosis. And of course, we had seen it on a US exam. And so following this, we then proceed with our lumen-opposing metal stent placement. And here we do this as a freehand technique as well. And there you can see first the lumen-opposing metal stent with the electrocautery enhanced tip is used to puncture into the jejunum. And here the stent is carefully positioned so that the distal flange deploys into the jejunum, and then the proximal flange deploys either on the stomach side or duodenal side, depending upon the case. In this case, it was actually the distal stomach that the stent deployed. So there you can see the stent. You can then, of course, dilate that stent up and then ultimately come back and perform ERCP. And so in this case, we opted to do that 11 days later. And here you can see entering with the cap assistance into that jejunum. And of course, that area of anastomosis is quite strictured down. Here we actually identify what we believe is where the orifice is, or the anastomosis is, and then gently probing with a wire, we were able to finagle into the biliary tree and introduce our catheter and follow up. And there you can see the cholangiogram with the significant stricture at the lower CBD, or at the anastomosis, I should say. And so this was very easily treated with balloon dilation, and following balloon dilation, you can see the good drainage that comes from the biliary tree. We opted to leave this stent in as we wanted to ensure durability of this response. And so after sweeping out the duct, we left our aluminum-opposing metal stent in, but left the patient without an stent in the biliary tree, partially because the area from the anastomosis to the bifurcation was so short that a covered metal stent would have been difficult to place. And I don't think the patient would have tolerated multiple covered stents. And so the lamps was left in place, and the balloon was the anastomosis was dilated to 8 millimeters, and repeat labs demonstrated normal LFTs 1 week later, and this persisted for 6 months. And so after 6 months, we opted to remove her stent, and she's continued to do well. So when it comes to the use of ERCP and altered anatomy, you know, we already saw Majidah speak very eloquently about the use of single balloon enteroscopy for the purposes of ERCP. Pooled analysis have demonstrated variable response rates, diagnostic success rates in this meta-analysis, at least of approximately 70%, procedural success rate of about 62%. When we look at using the EUS-directed transenteric ERCP method in patients, what we've seen in those that have non-gastric bypass Roux-en-Y surgical anatomy, what we've seen is really good technical success of this procedure, up to 94%. Now, again, very small study compared to the experience we have in other methods, but I think we're seeing more and more that this method gains traction. One thing to be aware of is that whenever we place these stents, there is the risk of misdeployment. And the biggest reason for lack of success is misdeployment of stent, which is technical failure. And this can result in 4 different types of injury. Type 1 is where the distal flange is in the peritoneum and not into the jejunum. Type 2 is where the distal flange is in the peritoneum and has also injured the jejunum. Type 3 is where the distal flange is in the jejunum and the proximal flange is in the peritoneum. And then type 4 is where the distal flange is in the colon and the proximal flange is in the stomach. These, again, is the most common cause of technical failure, is the misdeployed stents. And so, you know, when we look at the biggest study that's looked at this, 467 patients, misdeployment of stents occurred in approximately 46 patients, so up to 10%. And interestingly enough, the majority of these cases occurred in the first 13 cases whenever individuals were doing this. So I think experience definitely lends credence to be able to do this well. And when we look at the percentage of type of complication, type 1 is the most common, type 2 being the next most common, and actually type 4 is the third most common, followed by the type 3 injury. And so just as an example, you know, here you can see different methods in which we have to treat these. The vast majority in that study were treated endoscopically. The type 1 injury is closure of the gastric defect with an over-the-scope clip or a suturing. Type 2 would be removal of the lambs, and we can see an example of that here when after the puncture was made into the into the jejunum. You can see here the distal flange was not deployed into the jejunum, and as such, a NOTES procedure had to be performed where the scope is introduced, and then ultimately the stent is removed over a wire, and a new stent can then be placed over the wire, and this can be confirmed endoscopically as well in the jejunum, and then ultimately you can see the lamb's placement. And so, you know, again, the type 2 can be treated by removal of the lambs with the NOTES lambs replacement or stent in stent placement. Type 3 can be treated again with the NOTES or a lambs in stent within lambs over a wire placement. And then type 4, when you have that gastroccolonic injury, it's best to allow that fistula to mature, followed by removal of the lambs and then closure of the gastroccolonic anastomosis. So with that, I'll pause and thank you for your time.
Thank you, Shyam. And that was an excellent presentation. The videos of Eddie were really outstanding. I would actually have even all the faculties on video, and kindly unmute yourself, because we have a few questions coming in. Some questions have come directly to me and some have come directly to Amol. So this is one of the first questions that I would like to ask any one of them, is that can you place metal stents using balloon assisted ERCP? That's from some anonymous attendee. And I would let this question is open for all the faculty. So kindly chip and let us know what is your thought.
So I'll start with a comment. There are certain stents that can certainly be placed. I guess the big question becomes is what is the device you're using? That is the major question to answer first. So if you're it depends on the working channel of your scope in terms of the size of it as well as the length of the stent. And certain stents are out there, 6 French in diameter, that can fit through smaller channel scopes as well as longer length, 220 centimeters. And then but those are mostly uncovered stents. So you need to think about also the type of indication with which you're doing. And these stents may not fit alongside another wire, so it has to all be over the wire. So I think this is the type of stuff you have to be thinking about. But Boston Scientific, as an example, makes the Epic stent that I believe is about 220 centimeters in length and 6 French in diameter. That may give an opportunity for this.
Shyam, could you just stop sharing your screen so that we have all the faculty on the main screen of this thing? Yeah.
Sandeep, you want to
Thank
talk
you.
about this?
Yeah, a 6 French Cook stent also can be used, which or long wire. And I think the Evolution also has a long system which can be used.
Yeah.
And even a Hanaro stent, I'm told, is also long, can be used. So there are 3 options available.
All right. Okay, so I have another question for, probably any one of y'all can take it up. So see, most of these strictures that we have in an altered anatomy are hepaticojejunostomy strictures, and which are quite refractory, they're fibrotic, and they need either stents or dilate or things like that. So what is your preference? Do you only dilate them and leave them alone, or do you put multiple plastic stents, or do you put fully covered stents, or have you ever considered putting in lamps, or the 8 millimeter or the 10 millimeter lamps? So I would like to have each one's perspective on this. And probably add on to this would be also any role of the biodegradable stents in this situation, which are coming up again in the this thing.
I think it depends on the stricture type, if it is benign or malignant, and also discussion with the patients if the patients are willing to have multiple multiple ERCP, or he just want like less amount of ERCP. Because if we need to place plastic stent, then we need to change the plastic stent. So we need to have another ERCP, where using biodegradable is also good for patients with benign stricture. If it is difficult, we know that the patient might need multiple stricture, then I think metal stents will be the best option. I think discussion with the patients for me is very important. So I think all of them, we've been using all kind of the approaches.
Ivo, I think you come from a center where probably multiple plastic stents for benign strictures has been discussed a lot. So we would like to hear you regarding this.
We're the temple of plastic stents placement for benign strictures. Costamagna described this for the first time in the 90s. And since then, I mean, I can tell you when we place metal stents. In all the other situations, we place plastic stents. We place metal stents only in strictures due to chronic pancreatitis. So all the other patients have plastic stents because we have seen much better results because we place them progressively in increasing number. And the problem of metal stent is not it is not a question of costs. It is not a question of how you do it. It is easy and so on, fast. The problem is the diameter. Why? Because not every duct has the same diameter of the metal stent. And when you place it, the problem is the proximal part, because very often there is hyperplastic answer from the bile duct due to the foreign body. Sorry, that is connected to stricture at that level due to compression of a hyperplastic tissue. So we heal and we unheal. We do good and we do bad. This is why we use less and less metal stents. And I can tell you more. We are doing several studies on nanocomposite materials that could cover the plastic stents and avoid the biofilm creation. So we have just published in Nature a paper on the analysis of the biofilm that clogs the plastic stent. So if we could have a plastic stent of 10 French that is smart, that doesn't allow the clogging due to biofilm or sludge, then we have a perfect solution to the problem, because metal stents have technology that has been invented 40 years ago. So we are using all the time the same technology in lamps everywhere. There is nothing new in the 4 decades in the treatment of these patients. So we need new research in new materials. And this is the answer here. And until then, plastic stents, multiple plastic stents for benign diseases, at least, are the solution.
Thanks, Ivo. Shyam, Sandeep, you have any comments on this? Quick comments so that we can go to the next question.
I think the only thing that I would add is that whenever you're placing for these types of strictures, you want to kind of keep in mind the number of sessions you're going to need to have to come back for the patient. I think that becomes really critical. So if you're placing multiple plastic stents, or you're placing metal stent, the area in which and the ability to place these, because this is an altered anatomy approach, so it can oftentimes be quite challenging, and the type of scopes and the type of devices that you're going to use, you have to kind of think forward as to how it's going to play out for that case, and as well as the subsequent cases, to make it as easy and seamless and minimize any complications that go with it. And the question about lamps in this, you want to be a little bit careful, because if you're not going through the exact anastomosis, you're creating a fistula into that biliary tree, and then that still has the risk of closing down. Sandeep, any other thoughts there?
Yeah, the Japanese actually, Takao is a very strong proponent of using a plastic stent even for benign or malignant strictures. They do HGS with a plastic stent, and they keep exchanging that. Now, coming to the case in mind that we're discussing is a benign hepatic hilar stricture or anastomotic stricture. So they will place a plastic stent, dilate the anastomotic stricture, come out of the plastic stent and do an exchange every 3 monthly until they feel that the stricture has nicely opened up, and then withdraw the plastic stent permanently. So that's another way of tackling this. What the IR people do percutaneously, keep dilating or increasing the PTBD catheters each time with a larger diameter. The same process is now done through the endoscopic route.
Sounds great, guys. This is a question just for Sandeep, Majidah, or anybody wants to chip in. The direction of sphincterotomies while doing the double balloon enteroscopy is, especially in cases like Billrod 2 or even Roux-en-Y gastric bypass patients, would it be upwards or downwards? In short, would it be a cephalic sphincterotomy or a caudal sphincterotomy? The direction of the sphincterotomy is more important, because it gets confusing once you get to the ampulla in a retrograde fashion.
Majida, you will take that?
Well, I think it goes cephalic when we do the sphincterotomy.
So we need to have a sphincterotome which is oriented in such a way that it only cuts the biliary tract, and the autotomes can be turned around because it's now a retrograde kind of approach. You're looking at the papilla from below upwards. And if you do a regular sphincterotomy, you'll cut inferiorly, whereas we want to cut it more superiorly. So if you can turn it around, having said that, you can also, that's why people use more of a balloon than the sphincterotome. Just a small cut, allow the balloon to go in and stretch it open.
Okay.
And the
And
other
what
thing
about
we
the
can
needle
do
knife sphincterotomy over a
Wire?
stent?
Here the space is less. Yeah, you can place a stent and then do a needle knife, but with a wire going beside in an enteroscope is challenging because space is constrained.
Right.
And the other thing, when we do sometime retroflexion on that view, sometime and then we get the papilla on better orientations with using Enteroscope. It's challenging, but doing the retroflexion where the scope will be in the J shape, at least we have the proper orientations of the papilla. Sometimes can be helpful.
We have two more questions. Amol, you want to take one and then I'll take one.
Yeah. So there is one question on. Yeah, so I think this question has already been answered. Fully covered stents using the balloon scope, do they exist? I think there are 6 French delivery system stents available now.
They are uncovered stents.
But they are uncovered stents. So you have to use them only in malignancy because you're not going to be able to remove these stents. Massive hemophilia during a rendezvous procedure maneuver. So how do you manage? So that is one question. That's actually more into the EOS domain, not exactly an altered anatomy ERCP question, but we'll probably take that. Maybe Sandeep, you want to do that?
It depends on if it's an EOS way of entering the biliary system and it's causing hemophilia. That means you have punctured a major vessel. It's artery or vein. Most of the veins are forgiving and they'll stop, whereas arteries are more difficult to manage. And we need to have our IR guy ready in case of an arterial bleed so that they can embolize, do a quick angio and then do it. So we have to be working in tandem with our team around that we're doing such and such case. And in case there is a mishap, please bail us out. We do it other way around as well. We bail them out as well in difficult situations. So that's what friends are for.
So I would jump to the next question, which could be possibly the last question. This is for Shyam. In order to prevent the type 1 complication during EDI procedure, what is your suggestion that can be done while deploying the lamps?
Yeah, good question. So, there's a couple things that I like to do whenever I'm deploying. First and foremost, I like to have the jejunal limb in a long axis, or the stomach in plenty of space. Stomach isn't as much of an issue because you can get 3-4 centimeters pretty easily. But if you can orient for the jejunal limb, as the case I was showing, the jejunal limb in a long axis, then it gives you plenty of space to ensure that the distal flange is in to the jejunum appropriately. The second thing you can do, I always preload a wire into the lumen opposing metal stent. I don't do this over a wire, but I preload it so that when I advance my lumen opposing metal stent into that excluded limb, then I can have that wire available to me in such case that I need, in the off chance that that distal flange does not deploy into the targeted limb, because more than likely my delivery system will still be into that targeted limb. So it's very easy to pass the wire and gives me an opportunity to be secure. I don't want to do it ahead of that point because there's a risk that I can actually push away that jejunum and then make it more difficult for me to deploy that lumen opposing metal stent. The other thing that I do, of course, is I give the patient a paralytic agent right before I'm about to do the procedure. So, we talked a little bit about the different types of paralytic agents available, but I use glucagon. At least 0.5 milligram is given right before I'm getting ready to distend that small bowel so that it adequately creates stasis in order for me to safely do the procedure. And then, I think those are probably the main kind of steps that I take in this aspect. And one other thing you can do may have been visible a little bit in that procedure that I showed, but when you advance and start to deploy the distal flange, sometimes I'll continue to inch up the delivery before I completely finish that stage 2, so that I'm continuing to push against that distal wall of the targeted limb, but in essence ensuring that distal flange remains in that limb and doesn't get deployed more proximally. Sundeep, any other thoughts of what you might do?
I think I agree with you what you're saying.
Amol has one question.
Yeah. So, see, I think we saw a lot of hepatogastrostomies in all the presentations that we had today, plenty of them, and which were used as an axis for further intervention. So my question to all the faculty is that when we are using an HGS as an axis rather than just for a drainage, are there any technical differences? Do you leave the stent out into the stomach more or less? Because we need to calibrate the stent, we need to go in, because as you shared, it was difficult to get the cholangioscope in later on. And so any thoughts about that?
I think using a segment 2 duct, if you have a repeated interventions as a option, would be one way to enter, but that has a challenge too if it's not opening in the esophagus. Our puncture point has to be below the G junction, so that sometimes segment 2 also can be approached from the stomach. If that gives an access, then in a benign biliary interventions where repeated access is required into the biliary system, I would place a fully covered stent through a segment 2. And you rightly pointed out that not long length has to be left outside, maybe about 3 centimeters or so, not 5, because this also shortens up. I don't want to take a chance of a fully covered stent migrating to peritoneum and causing more disaster. So I'll be very cautious about that. If I see that the stent is more hugging the gastric wall, I'll probably clip it or anchor it in some way that doesn't go inside.
Okay. Ivo, you have anything to add?
So it depends what you're doing. If you puncture the liver just to pass a wire, then you can also leave it like that and don't leave anything.
We're doing it as an axis. So we're placing
Yes, it's an axis, then I would leave it without anything. Or if you're not comfortable, you can place also a double pigtail stent. The problem with a metal stent, I think, is that it can create a fistula connection between the liver and the stomach, especially for benign diseases. We don't want to leave stuff inside. At least, I mean, it's just puncturing past the wire and then remove everything at the end could be the best solution.
Okay.
It depends on the site and what is indication.
Thank you.
Shyam, you want to add on this?
Over to you, Truptesh. Yeah.
Shyam wanted to add something.
Yeah, Shyam.
I agree with what's been said, and typically just as an axis, I typically won't do anything else with it as Ivo described.
All right, guys, we are almost 3 minutes above our designated time and allotted time. And I really thank everybody on behalf of Amol and myself and Free Endoscopy and also Boston Scientific that you guys came on a weekend, especially on a Saturday in your busy schedule, and taking out time from your family and enlightening us with your expertise. So we really appreciate that. And I would hand over to Amol to wrap up with the final comments of the video, which are going to be eventually will be sent on the Free Endoscopy so that other people who have logged in can also look into that. So thank you very much from our end. But again, Amol, I'm handing over to you just for the final comments.
Thank you. Thanks to Truptesh, and thanks to all the faculty and, for their inputs and for all the education, and thanks to all the attendees. And we would also like to thank Boston Scientific Corporation for supporting this educational initiative. And we understand that although many attendees register for this webinar, many of them are unable to join in live due to time zone differences. And because of this, the recording of this webinar will be uploaded on the Free Endoscopy YouTube channel over the next couple of weeks, very likely. And if we would request you to follow our YouTube channel, the Free Endoscopy YouTube channel, so that you get notifications, and then you can view this webinar at your convenient time as well. Now, we do this East Meets West webinar every 3 months approximately, and we would like to announce the topic for our next webinar. And that will be on, again, a third space endoscopy topic of very common interest and very popular, that is on POEM. So the date is, we're still trying to finalize the dates. It will very likely be end of August or early September. But keep watching us, watching this space, and you will hear from us very soon. And keep an eye on our next announcement. And with that, and very, very soon we will come back with that. Of course, it will always be on a Saturday, and the time will always be 6:30 p.m. Indian Standard Time, and it will be 9 a.m. Eastern Standard Time. And as per that, you can figure out the time zones for the rest of the world. We can do that. So with that, we would like to sign off, and thank you so much once again for being part of this webinar, and we hope to see you soon, and have a great weekend. So bye-bye.
Bye.
Thank you. Bye-bye.
Thank you.
Thank you.